During puberty, levels increase. Then during their normal productive life, you've got enough estrogen and progestin to maintain ovulation and regular menstrual periods. In the late 30s, early 40s, most women start to get then a decline in their levels of these hormones. And we call that perimenopause, peri being within or between. During that time, the decrease in these hormones is not really smooth, and you can see from the peaks and valleys here that they really go up and down. So then when women get around 50 is the average age that women hit menopause, which is actually the term for the last period. That last menstrual period and the time around that we're calling menopause. And then after that, those hormone levels have completely flattened out, and we refer to that as postmenopause. So some of the effects that we see during perimenopause have a lot to do with fluctuations of estrogen levels, such as hot flashes. Then as menopause itself actually hits, then we're going to see lack of ovulation. And during postmenopause, you'll see reductions in hot flashes and more long-term changes. So some things that you need to be able to memorize, and I'm not going to have you distinguish between whether they're perimenopause, menopause, or postmenopause symptoms. But as those estrogen, progesterone, and testosterone levels have declined, we see thinning of the hair on the head, but changes in the body and pubic hair where the hair can become darker and thicker. Because estrogen is growth hormone at breast tissue, with the reduction of estrogen, we see changes in breast size, the breasts droop and flatten, the nipples become smaller. We also see changes in mucous membranes and skin, including changes in vaginal skin, in which there's less lubrication. Vaginal tissue becomes drier. It also shrinks, and what they're referring to there is that the tissue itself gets thinner, and so it's actually, since it's thinner and drier, it's more sensitive and it can rip and tear more easily. And so some women can find intercourse to be painful. We see changes in muscle tone. Often we can see stress or urge incontinence. That means that with sneezing or picking something up, that type of incontinence where there's urinary leakage because of something that's put pressure on the bladder. One of the things we see is decrease in bone mass and strength, and these female sex hormones promoted osteoblasts. So they promoted healthy remodeling of bone tissue. Without that, the bones are becoming more fragile, and that's why we see an increase in osteoporosis risk after menopause. We also see a risk of cardiovascular disease. Interestingly, females before menopause have a much lower risk of cardiovascular disease than men do, and we think that estrogen at that point in time may be protective. And so losing that natural estrogen at that point can then increase the risk to that of their male counterparts. And we see some other things like backaches and tissue around the gums and teeth changing. So it's really important to go back and review the two main sets of risk that we see with estrogen and progesterone. When I say estrogen, I'm usually referring to estradiol, which is the body's main estrogen. So estrogens are a group of hormones that all act at the estrogen receptor, and progestins are a group of hormones that all act at the progesterone receptor. So our normal progestin in the body is progesterone. So the first thing we want to emphasize is that estrogen and progesterones are both pro-clotting. Because of this, they increase the risk for thrombotic events. Thrombotic events are going to include ischemic stroke, MIs, venous or arterial thrombosis, and thromboembolisms, which are the clots or thrombosis that move, and pulmonary embolism. It's important to recall that estrogens are much stronger clotting risk than progestins are. So progestins can have clotting risk, but it is much smaller compared to what you're going to see with an estrogen. And then, as always, pharmacologically, these risks are dose dependent. A high estrogen dose is going to really increase your risk for a thrombotic event. The other thing that we want to remember about estrogen and progestins is that estrogen is a strong growth promoter at several tissues, where progestins often can counter this estrogen growth activity. They don't do that in all tissues, but they do that in many. So estrogen is a growth promoter in a lot of different things, but when we talk about menopausal treatment, we're really most concerned about its growth promoting activities at ovarian cells, endometrial tissue, and breast cells. So estrogen effects here are they're going to increase proliferation of cells in all of these cell types. So by increasing proliferation, you're increasing cancer risk. Progesterone, naturally, or progestins as a class, are going to suppress proliferation of ovarian cells and of endometrial cells. So they're going to be opposite effects from estrogen. However, the progestins are not having an effect here at breast cells. So you want to remember the estrogen is increasing cancer risk at ovarian, endometrial, and breast, and that progestins or progesterone are going to decrease cancer risk at ovarian and endometrial cells and have no effect here at breast cells. So those differences in modulation of proliferation became really important when we started first hormonal replacements. When doctors looked and saw, oh, these female hormones are decreasing during menopause, they assumed that estrogen was the most important one and decided to give fairly high doses of estrogen only. What they saw at that point was an increased incidence in ovarian cancer, in endometrial cancer, and in breast cancer. So that's not really surprising. One of the things they realized was they were giving a very high estrogen dose and really didn't need to give it that high, so they decreased that dose. But they also then realized that, wow, if progestin is naturally in the body along with estrogen, and if progestin has the suppression of proliferation effects, then what if we gave them as a combo? And so now almost all hormone replacement therapies are combination. So what is the effect on these cancers if you're giving a combo treatment? Well, on ovarian cells, you've got the increase, but that's counteracted by the progestins, so you don't really have an effect on cancer. So there's no increase when given as a combo. Same thing with endometrial tissues. The estrogen might increase the proliferation, but the suppression by the progesterone means you don't have an increase and no effect on endometrial cancer. On breast cells, it's a different issue because you do have that estrogen proliferation, but you don't have any suppression by progesterone, so you do see an increased breast cancer risk. So because of that beneficial profile of combined estrogen and progestin treatments, most all hormone replacement therapies you're going to see now are going to be a combined hormone replacement. So when they say combined, they're talking about both estrogen and progestin. So when you give a treatment with both estrogen and progestin, what we see are some pros and some cons. Medically, we have some benefits in that they reduce osteoporosis because estrogen is enabling the remodeling of the bone. When you reduce osteoporosis, you reduce hip fracture. That may sound like a small thing, but in reality, that's very important because when you think about older people, they fall, they get a hip fracture. What happens? They end up in bed, and often the people who are bedridden die of things like pneumonia. So osteoporosis itself can lead to increased mortality. So that is a really important thing to be thinking about. Combined HRT decreases colorectal cancer risk. It decreases the hot flashes that women might suffer from, and it decreases that vaginal discomfort. However, if a woman wants to address vaginal discomfort without adding any of the other effects that a systemic hormone replacement may have, they can give estrogen or a combined, so intravaginally. And that would keep all the other effects down because it would be just a local drug concentration. Like I said, with the combination, because you have estrogen and progestin, we don't see any clear increase for endometrial or ovarian cancer risk. So those sound really great. Looks like every menopausal woman would want to take that. However, they do have cons. And the cons are that they increase your risk of coronary artery disease. Although when they look at subgroups, that's generally only in patients that have metabolic syndrome that increase occurs. Increases your risk of hypertension, increases the risk of dementia, and as we would not be surprised, because we know that estrogens and progestins can both be pro-clotting, you're going to have an increase in risk of blood clotting. So any of those thrombolytic events, what we see is that it increases the risk of stroke. And when we say plus 8 cases out of 10,000, what we're saying is 8 additional events per 10,000 people. So not 8 people out of 10,000 will have a stroke, but we're increasing it by 8 people. And then we see that thrombolytic event from an MI as well. So those are some clear increases in clotting or thrombolytic events. We also see that the combined does increase breast cancer, and we see that it increases it by about 8 cases per 10,000 people. But because breast cancer is being found earlier and being more effectively treated, what we're seeing is the number of deaths from it is actually increasing 1.3 deaths per 10,000 people. So when you look at these pros and these cons of combined HRT, you can see that this is really going to depend on an individual woman, whether replacement therapy is a good idea for them. So in your clinical courses, when you talk about making decisions, you can see that maybe someone may have a very high osteoporosis risk and family history of colorectal cancer. This may be a really good benefit for them. However, if there's someone who's had a stroke before, has a high family risk of breast cancer, and has metabolic syndrome, then maybe this would be a really terrible choice for them. So this is one of those agents that's really going to depend on the patient specifically. So I briefly mentioned that there are a lot of different estrogens, and estrogens is the class category. When we talk about estrogen, we are usually referring to the main estrogen that our body makes, which is estradiol. When we talk about conjugated estrogens, what we're talking about is a mixture of different types of estrogens that are all coming off of this estradiol. So the synthetic pathways for estrogens are going to be really complex, and there's going to be a lot of different types of estrogens that can be made within the body. So in the body, while estradiol is the main estrogen, there's multiple different types that are made. You see the same thing in plants. So plants that we use for estrogens like soy are going to make multiple different types. And this is just 9 estrogens. There are multiple more estrogens out there. I just wanted to kind of give you an idea. So our med chemist friends have gone ahead and created a version of estradiol called ethinyl estradiol. And you're going to see ethinyl estradiol in almost all orally available estrogen drugs. There is a new one called mestranol that's also PO bioavailable. So from what you know already about what estrogens do themselves, it shouldn't be surprised that there's a FDA black box warning for all unopposed estrogens. And so unopposed means estrogen without progesterone. And some of the risks for that are going to be cardiovascular disease, breast and endometrial cancer, and increase in dementia. So you need to know those black box warnings. So let's get to some of the drugs that are out there. While we said that in most cases we're giving combination hormone replacement therapies, there are still some estrogen-only treatments out there. And so the class here are estrogen replacement. So these are unopposed, and they're going to be estradiol or they're going to be estrogen receptor agonists. One of the brand names for estradiol is going to be Viveldot, and that's available in a patch. And the reason that it's in a patch is to increase that bioavailability, since it has poor oral bioavailability as well as just convenience. We also commonly see Premarin, which is a set of natural conjugated estrogens. And so by natural, we mean that it's not synthetic in a vat, that these are made from animal sources. And they're conjugated, which means they're that mixture of different types of estrogens. They're not estradiol alone. Premarin has a great name, and the name came from the original source of these, which was pregnant mare's urine. So pregnant mare's urine. And the reason that they got it from this is when a mammal is pregnant, they have high estrogen levels. So they would collect urine from pregnant horses and then purify out the estrogens from it. It is important to know that this is animal-derived because some patients may have ethical concerns about taking a drug that's derived from contained animals. So this can be a PO tab and can also be given as a vaginal cream. So because this is unopposed estrogen, if I ask you about adverse effects, you're going to want to be able to consider any of those estrogen-only effects that we talked about. We want to emphasize the increase in those cancers, breast, ovarian, and endometrial cancer, and you absolutely need to always know any black box warning associated with any drug. So when we think about these different formulations, patch, PO tab, or vaginal, which formulation would you expect to have the least side effects? And that would be the one with the lowest systemic concentration. So a patch is going to have a high systemic concentration because you're getting that in the whole body. Anything taken PO is going to have a high systemic concentration, but the vaginal cream has a lower systemic concentration, and that's going to have the majority of its effects in the vaginal tissue. So that's one reason that Premarin cream may be less of a risk than a systemic agent. So the combination, estrogen and progestin, HRT, and I say progestins here because they can be many of the different chemically derived progestins, and these are given PO in general. The mechanism is, of course, that they're going to be agonists at estrogen and progestin receptors, and the most common ones, some examples I'm going to give you are Angelique, which is estrogen plus drospirenone, and then Prempro, which is conjugated estrogens plus medroxyprogesterone. And a great way to remember Prempro is the estrogen plus progestin combo, is that Premarin was the estrogen only, and the progesterone is the pro. So we went from Prem to Pro. These are PO, and their adverse effects, you're going to remember the combined EMP effects that we had talked about, and you're going to think about the fact that these are systemically administered. So we've talked about agonists, we've talked about partial agonists, we've talked about antagonists, and we've talked about allosteric agents. Another class of ligand that we haven't talked about before are receptor modulators. This is a really simple explanation of what a receptor modulator is. You can go into a whole field on these. So we're going to talk right now about selective estrogen receptor modulators. And what these are is they're ligands that, when they bind at estrogen receptors in some cells, will act as an agonist. And when they bind to the same receptor in other cells, will act as an antagonist. And this goes against everything we've talked about in terms of pharmacology and pharmacodynamics before, because we always assumed that, say, you had a serotonin 2AB subtype receptor, that if it was on one neuron, an agonist at it would have the same effect as it would have if that same receptor was at a different neuron or a different tissue. And for the most part, that's true. But one thing that we don't really talk about a lot is that different types of organs and tissues can modify those receptors. So they can phosphorylate, they can have other factors within the cell. And so a breast cell may modify its estrogen receptor in one way, while an ovarian cell may modify its estrogen receptors in a different way. So you can have the same agent, which are these SERMs, come in, and when they bind to one of them, they act as an agonist, and when they bind to another one, in a different cell, they act as an antagonist. So this just makes everything far more confusing. This is not an effect that you're going to see for most drugs, at least not at a level that makes any difference. You will see these for progestin receptor modulators and estrogen receptor modulators. So with these selective estrogen receptor modulators, what we're going to see is that the estrogen receptors in breast cells are actually somewhat different than those in bone, liver, and uterine cells. And there's all sorts of different other cells that are going to have estrogen receptors that we're not looking at right now. So the SERMs that you're going to learn about are going to be clomiphene, tamoxifen, and raloxifene, as well as ospemifene. Clomiphene is used as an infertility agent, and the only one we're going to talk about in this lecture is really going to be ospemifene. So imagine me sitting at the dentist's office, and I'm out in the waiting room, and I pick up a magazine. I flipped through it, and then I saw this ad, Vaginal Aging and Osphena. The first thing I saw was FDA-approved non-estrogen oral treatment that relieved painful intercourse due to menopause. So the first thing that I think, and the first thing you would think, is, wow, I thought estrogens were the main way to relieve painful intercourse during menopause. So now I'm really excited. So what is this drug? Looking at this ad, I looked at this non-estrogen oral treatment and thought, wow, this is going to be great. We're not going to see estrogen-induced side effects. But being a pharmacologist, the first thing I did was pull out my cell phone and Google it. So what I saw when I Googled this is that it is a SERM, a selective estrogen receptor modulator. So it acts as an agonist at vaginal tissue, endometrial tissue, and bone, and it acts as an antagonist at breast tissue. So for the use of this, does this make sense? Well, it's to relieve painful intercourse, And we know that estrogens do cause vaginal tissue to thicken and be more lubricated. So yes, absolutely, a functional agonist would help relieve painful intercourse. So knowing that mechanism, that it's an agonist at those tissues, okay, looks like that'll work. It's an agonist at endometrial tissues, so that's a little bit concerning because I'm thinking it could potentially increase endometrial cancer. But it's also a functional agonist at bone estrogen receptors, so that's great, might help reduce osteoporosis. Then it's a functional antagonist at breast tissue. So what that tells me is it is either not going to increase breast cancer or even decrease breast cancer. So I'm looking at the magazine ad that says non-estrogen, and I'm looking at my cell phone where I've Googled the mechanism that says it's a SERM. Technically, the manufacturer has not lied because this is not an estrogen, and it is technically not a pure estrogen agonist. It's a SERM. So it's a non-estrogen oral treatment. So while legally they may be correct, most people would expect from looking at that it wouldn't have those estrogen-induced side effects or estrogen dangers. We've looked at that critically from what we know about estrogen effects and come up with a concern about endometrial effects. And then also we're probably thinking about, what about stroke? What are the clotting effects of this? Because it didn't mention whether this is an agonist or antagonist in the clotting cascade. So let's see if our concerns are right. So as I'm sitting in the dentist's office, I'm getting more and more upset. I'm starting to get grumpy. The other people in the dentist's office are looking at me because I'm flipping back and forth between the ad and my phone, and I'm grumbling to myself. And I get to the boxed warning, and it says risk for endometrial cancer and risk for cardiovascular disorders, including stroke and deep vein thrombosis. So understanding what estrogen activity does in the body, we can look at a new drug that comes out and automatically recognize some of the issues that you might see with it, even if those issues aren't being highlighted in the information that patients are seeing. So what's our takeaway about Osphena? It's a SERM, an estrogen receptor modulator. You need to know what a receptor modulator means, that it's acting at these receptors differently in different tissues, that it is selectively an agonist at vaginal, endometrial, and bone tissue, and functionally an antagonist at breast tissue. You also want to know anything that's in any black box warning that I give you, so increased in clotting issues, and then we realize there actually is an increase in endometrial cancer, ospemifene or Osphena, and it's given PO, so you are getting those systemic concentrations, so those concerns really are real. So you want to think about the adverse effects of this, and they're going to be similar to any estrogen, except at tissues where it'll act as an antagonist. So there's a potential that there may be a decreased risk of breast cancer, but we don't have enough evidence yet. So let's add ospemifene or Osphena to our table of cancer risks. So we had our ovarian, endometrial, and breast cells, and we saw that if we gave an estrogen-only treatment, we increased cancer risk in all three of them. Then we saw that if we gave a combo EMP treatment, we opposed the risk in ovarian cells, so we didn't increase it. We opposed the risk from estrogen in endometrial cells, so we didn't increase it. And we weren't able to address the issue in breast cells, so we still saw an increased risk in the combos. So now what did we see with ospemifene? We saw that they said that it's a functional agonist at endometrial tissue, a functional antagonist at breast cell tissue, and they didn't mention what it was doing at ovarian cells. So ospemifene alone, we would suggest had an increase in cancer risk for endometrial cancer and a decrease in cancer risk for breast cancer. So if I asked you guys to compare these types of menopause treatments, estrogen only, combo, and ospemifene, you would want to be able to tell me what effects each of these would have on these cancer risks, and recognizing that you don't know what the effects are on the ovarian cancer. So there's a last treatment that I want to mention because it's not exactly estrogen and it's not a combo treatment, but it still has estrogen effect. So it's called Prostrone or Intra-Rosa, and although they're using the name Prostrone, it's actually the same thing as DHEA. And DHEA is here a precursor for estrogen synthesis. So we had DHEA, then that went to the androstenedione, to testosterone, and then to estradiol. So you're giving DHEA, but you're ending up with estradiol itself. So the mechanism here is it's a precursor to estrogens. It's given vaginally as an insert nightly. And if you forget the route of administration, intra-rosa. They even give you the rose here. And because it is local administration vaginally, it should have few systemic effects. So they're not really concerned with a lot of adverse effects here. So there are a lot of other menopause therapies that we can't really cover in this lecture. There are other hormonal replacement therapies that can range from using what we call bioidentical hormones, which are hormones that are synthesized chemically from precursors in yams or soy into the estrogens that we find in the human body. Estradiol as the main one, but also there's other conjugated. And we have herbal therapies that have estrogen agonist activities. It's hard to know with few studies out there how effective these are because everything is dose dependent. And at the concentrations that people are taking these therapies, I don't really know whether it's having a significant pharmacological effect at estrogen receptors. There are also some adjunct therapies that don't act at estrogen receptors, and those are things like paroxetine, which is really just given for hot flashes, so that autonomic effect. So thanks for sticking with me, and I hope this was interesting and helpful to you.